Next is about the motor neuron diseases. Now, motor neuron disease word itself is a broad word which includes a large number of varieties of conditions. Of course, in the neurological textbooks, you will find something around 30 varieties of these nomenclatures for the motor neuron disease, and that all the nomenclature would be really making the issue more complicated than really of any clinical use. So, I would try to make it more simplified as far as possible, and based upon that, the simpler classification, motor neuron diseases could be grouped under three heads: upper motor neuron alone, which is also called as primary lateral sclerosis, or lower motor neuron alone, that's also progressive muscular atrophy and spinal muscular atrophies. Then upper and lower motor neurons, which is amyotrophic lateral sclerosis. As far as the clinical incidence is concerned, the upper and lower motor neuron disease, the amyotrophic lateral sclerosis, is more common, and you will see a large number of patients of that sort now, and hence we will go in that sequence of higher clinical incidence as such. Amyotrophic lateral sclerosis is also known as, the other names are Charcot's disease, Lou Gehrig's disease also are the other names. By definition, it's a slowly progressive degeneration of upper motor neurons as well as lower motor neurons, and 75 to 80% of the patients, symptoms begin with limb involvement, starts with the symptoms in the limb in majority of the patients, where the patients will have the typical clinical symptoms of reduced strength and weakness in the limbs, upper and lower limbs. There again, the upper limb is more frequently involved than the lower limb in majority of the conditions, but as per the data, it's almost equal. But what we see in the clinical practice is upper limb is more frequently involved. About 20 to 25% of patients present with the bulbar symptoms in the sense swallowing difficulty, palatine movements, and dysphagia, and patient would not be able to swallow, or the speech would be affected in such patients, and that's in around 20 to 25% of patients. Some of the patients may have both the limb involvement as well as the bulbar involvement. As far as the clinical presentation is concerned, the amyotrophic lateral sclerosis conditions are categorized into 4 region involvement. That bulbar involvement, where the nerves and muscles related to the face and the swallowing, they are affected. Then cervical, where the upper limb is involved. Thoracic, the thoracic area is involved. Lumbosacral, the lower limb is involved. So some of the patients may have any of these secluded regional involvement, certain regions only involved. In some of the patients, all the regions could be involved. And more frequently, as I told you, it's the upper limb which is involved first, and then the lower limb may be involved in larger number of the patients as such. Now, the bulbar symptoms are usually, the symptoms are seen as the patient's family notices slurring of the words initially, or choking during a meal. So the symptoms in bulbar conditions start with the slight slurring of the speech, which may not be really noticed by the patient, but the attendants of the patient or somebody who is near the patient may observe that the patient's speech is gradually losing its character. Intensity of the speech also may be reduced, or the initial most symptom could be simply the patient would find something difficulty during swallowing. He may be able to take the food, but during the consumption of the food, on some occasions, there could be a feeling of choking during the food. Then gradually, the condition may progress, where the patient may have a significantly impaired speech as well as the swallowing difficulty. The course of the disease is usually very slow, but in some patients it could be somewhat rapid also. So the time taken for a significant presentation of the symptom it may take from a few months to few years in many of the patients. And sudden development and the sudden complications can occur if there is an aspiration. If the patient gets aspirated, the food gets aspirated in the respiratory tract, it may present with acute respiratory symptoms or air hunger, or even occasionally fatal complications can occur in such patients. But development of such a acute event as the beginning, it would be rarely seen as such. A few of the patients may have the symptoms like where their previous evolution of the symptom might not have been noticed, and only the patient may develop a sudden event and then a fatal complication may occur, but that's a relatively rare sign. Then as far as the limb symptoms are concerned, the initial symptoms will be patient finds a wrist drop, and particularly those persons who do more work with the hands like writing or typing and so on. So such finer jobs would be difficult for the patient, or patient may be finding it difficult to grip some object like a pen or such even light objects. Actually, the symptoms are seen with the light objects first than the heavy objects. When you carry a heavy weight, all the muscles in the body, they would take the active part, and hence the patient may not notice at that moment in the beginning. In the beginning, it would be related to the lighter object like holding of a pen, holding of a needle, and or holding a spoon and so on, that the patient may find it difficult to hold, or maybe at times it may fall without his control, or the patient may have a wrist drop, the wrist movement may be reduced. And or the patient may feel that his handwriting is abnormal, or patient may have a feeling of cramping or stiffness, or even wasting of the hand muscles, finer muscles of the hand may be presented. In some of the patients, fasciculations could be seen in the beginning, and fasciculations in the tongue also may be seen in the beginning. That fasciculations is a fine tremor-like appearance where the muscles, spindles will be contracting. Then there would be a set of the patients who may present with the pseudobulbar symptoms, which can present with the exaggerated and involuntary emotional responses, like the patient may have either a laughing or crying without any specific cause, which is not under control, and the patient may even have a difficulty in expressing the proper emotions. That could be a relatively less common, but this is called as pseudobulbar symptoms. And some of the patients may present with these complaints also, which may often be confused as a psychiatric issue, but it may not be a psychiatric issue, it may be an organic issue. Then most of the patients may retain the functions like extraocular movements, bowel movements and bladder movements are controlled till very late stages. That's a very characteristic feature of motor neuron disease. Patient may have impairment of all voluntary functions. Involuntary functions are rather somewhat partially involuntary functions like the bowel movements and bladder movements. Ocular movements like the eyelids movements, they are not affected till very late stages in such patients. Some of the patients may develop urinary symptoms because of the urge incontinence or constipation because of the abdominal muscles abnormality, but the sphincter control is not affected. The patient may still be able to pass the stools. Now, definite diagnosis of amyotrophic lateral sclerosis in the early stage is almost not possible, and most of these symptoms are so innocuous that usually either the patients may neglect or the clinician also may neglect. Now, as per the standard World Federation of Neurology diagnostic algorithm, the classification of the symptoms and the necessity for making the diagnosis are they are categorized as a clinically definite one, or clinically probable lateral sclerosis, or clinically probable and laboratory supported ALS, and clinically possible and clinically suspected. Now, clinically suspected conditions are those where the patient may present with only lower motor neuron syndrome, which causes lower motor disease adequately as such. That's why the patient may feel like a laxity in the muscles, maybe, and the patient may, usually the complaints are limited to that, laxity in the muscles, finding it difficult to hold a object, only that much of the symptoms. Then clinically possible will be where the patient may have both upper motor and lower motor neuron signs, at least in one body segment, and the upper motor neuron lesion signs would be like the patient may have even slight increased reflexes, or maybe the reflexes may be exaggerated, or maybe slightly normal. But lower motor signs are quite prominent, and the patient may show mild atrophy also, but EMG studies may be normal. Clinically probable or laboratory supported is when the patient may have symptoms of upper motor and lower motor neuron signs in the segment, any of the segment, and there could be a obvious EMG changes, and at least in two limbs. That's considered as a clinically probable with the laboratory supported. And clinically probable is when the patient has the signs of upper motor neuron lesion at least at two body segments. In the body segments, as I told you, like the cervical, this bulbar and thoracic part, so on. So there, the patient may have more severe clinical symptoms as such. And the upper motor neuron lobe ends in more than two segments, three body segments, is confirmed as such. There is no test which can confirm the diagnosis of motor neuron disease. Even EMG would be helpful only in the later stages. Then the current trend is genetic study. Genes now responsible for the amyotrophic lateral sclerosis are now identified, and it may be one of the means by which you can predict the possibility of ALS. But again you have some issue like one is genetic study is not possible in routine all patients, only in a few of the patients it may be possible because of the lack of facilities. As well as the other is there could be many people who may have the genes in them but they may not develop the symptoms as such. So that's also the other issue. The electrodiagnosis is that's EMG is one of the dependable diagnostic method, but again it's not confirmatory. The sensitivity of the test is relatively lesser, and moreover the changes which are seen in the electromyography study are comparatively very little. Totally the amplitude of the muscle contraction would be lesser and there would be slight irregularity, and hence the chances of missing this also are quite common. See, a normal and ALS patient, the activation period is slightly longer and there could be some abnormal slight movements which may be often missed, and hence the sensitivity of the test is quite low. A negative test may not confirm the rule out the diagnosis completely. So more or less you have to depend upon the course of the disease as it evolves. And once it is confirmed, there is absolutely no curative treatment. There is absolutely no curative treatment for amyotrophic lateral sclerosis. All that what we can do is improve the quality of the life by taking care of the day-to-day activities. For taking care of the day-to-day activities now, lots of instruments are available which can support, which can facilitate the movement. It could be like the artificial instruments which can help in movement. Now new technology has come up and lots of such instruments have come up which can support the daily activity of the life. Then if the patient has a bulbar symptom and is not able to swallow, then the tube feeding is the only alternative. I think you might have seen a few patients where the tube feeding was being continued and then we have treated and we could remove the tube in some of the patients. Then if the patient develops a respiratory failure, then invasive respiratory support also is the other part. Till very recently, till 1996, there was no question of any specific drug as such. 1996, riluzole was approved as a disease-modifying drug. But even there, with the riluzole, now we have seen a large number of patients on riluzole, which doesn't really produce any huge significant change. The only thing is it may slow down the progress of the disease, and the riluzole also is quite a costly treatment. But with our clinical experience, I have treated a few of the patients, and the usual prescription would be Chandraprabha Ekandira Ashwagandharishta, considering this as a Dhatu Kshayajanya Vata Prakopa, and Rajayapan Bhustvira Tailadhara is seen. And what I have observed is Pindaswera done in such patients may worsen the condition. So that's our clinical experience. Again, I don't say that the patient can be cured, but many of the patients can be improved upon. At least in a few of the patients where the patient was dependent upon tube feeding alone, we could avoid the tube. Patient can swallow now normal food. Speech also has improved in a few of the patients. Then as far as the skeletal movements are concerned, the movements of the limbs and then activity, the changes are not so remarkable. But still some changes can be done and the patient's life can be, quality of life can be improved. Then comes another of the upper motor neuron disease, that's the primary lateral sclerosis. Now primary lateral sclerosis compared to the amyotrophic lateral sclerosis is less common. But because we are discussing the chapter as such, we refer to this issue also. It's a progressive degenerative disease of the upper motor neurons, and characteristically it's presented with the stiffness of the muscles, spasticity or stiffness, and it affects the lower extremities, trunk, and then the upper extremities, bulbar muscles later on, the last stage. Usually, the development of the symptoms will start with the same sequence, like the lower limbs first involved, then the trunk, then the upper extremities, and then the bulbar muscles are involved. And the exact etiology is not known. Even the genetic studies also are not conclusive. Then the typical clinical presentation is the patient may have a pain and stiffness due to spasticity in the limbs, and onset is usually asymmetrical, in the sense it may be in one limb and then later it may go to the other limb, it may start with the limb, and most of the times these symptoms are presented as if they are cramps. Patient may have a stiffness in the legs, and because of the stiffness, patient's gait may be slightly altered, and the pain also may be presented. So often this may be either considered as cramps, or maybe the other common diseases like osteoarthritis or lower limb pain conditions, any of the other lower limb pain conditions. Characteristic feature of this primary lateral sclerosis would be the patient would find it difficult to climb the stairs up when the movement is climbing up. Bone diseases like osteoarthritis, the patient may have pain more when the patient descends down, whereas because of the stiffness, patient may find it difficult to move up. And when the patient walks on a level floor, there again, patient may not feel like comfortable. The legs may be slightly wavered. He may have legs may be slightly diverted, and that kind of a position is characteristically seen. Then as the condition progresses, patient develops a difficulty in maintaining the balance over the body, and there is a tendency to fall. Now at that stage, the diagnosis is relatively simpler. Patient may have a difficulty to maintain the position, particularly when he walks, and there again the incidence of fall will be more when the patient climbs up than really the difficulty in moving down. And even in the level ground, the patient may have the complications of feeling like a fall or really fall as such. Then the involvement of lower back and neck also may be not presenting with the neck pain, and it may even the back pain, which again may be often confused with the other common causes of the neck pain and back pain like the spondylosis. As the upper extremity is involved, patient may have difficulty with the activities of daily living like writing, eating and so on, where again the stiffness is the most common. When the patient eats, the hands would move away from the mouth, and then there could be a spillage as such. And the speech also may present with the dysarthria, which may be mild, and then gradually progress. Swallowing and breathing also may be compromised at the later stages, and there is no specific investigation to confirm the pathology. So primary lateral sclerosis is primarily this clinical diagnosis, and there is absolutely no curative treatment. And the current protocol of the treatment to improve the condition is muscle relaxants like baclofen and alpha-adrenergic agonists, tranquilizers, diazepam, tizanidine are often used as such with very minimal results. And usually what I have treated a few of the patients, though the incidence is much lesser than ALS, the outcome is somewhat satisfactory. Again, I will not say that it's a curative treatment. Smilsagar Ekangula Ashwagandha with the Tailadhara and Matra Basti has given some satisfactory improvement. At least the rigidity gets reduced, the spasticity gets reduced, and as the spasticity gets reduced, the activity of daily living can be somewhat improved, and that's one of the options of the treatment. Then comes the other conditions which mimic the motor neuron disease, which also are variants of the motor neuron disease. That's the focal muscular atrophy. Of course, now as far as the conditions classification is concerned, it may be a controversial, like whether it has to be considered as motor neuron disease or whether it's a muscular focal muscular atrophy as a separate issue. As far as the muscle atrophy is concerned, the muscle atrophy could be produced due to large number of conditions which are non-neurological, like infections, trauma, inflammation, spinal cord disorders, vasculitis, entrapment is in the sense compression of the muscles, immune mechanisms like many of the immunological conditions can produce the muscle atrophy, toxins, physical agents such as electrical or radiation injury, genetic and enzyme defects that can produce the abnormality in the muscles. So our discussion now would be limited only to the neurological induced muscle atrophy, not the other conditions. A patient presenting with atrophy of the muscles need to be investigated, and you have to take a detailed history, and all those other causes have to be ruled out. Then only we can consider whether it is a neurological induced atrophy or not. Now, as far as the other conditions of the muscle atrophy, we may discuss later on when we discuss the other context. So, we limit only to the neurological induced muscle atrophy as such. Now, the neurological pathology resulting in the muscle atrophy is one of the common condition is what we call as the focal muscular atrophy, and other is the spinal muscular atrophy, the major two important conditions. Then of course you will have a large number of syndromes. If you see the neurological textbooks, there will be around 15 to 18 types of the syndromes related to the muscle atrophy. I think all that would be unnecessary. We will minimize the details to those conditions which are seen clinically quite somewhat frequently. That's the only issue. So when I have selected these issues, it's from that point of view of a possibility of a incidence in the clinical practice. And among them, the focal muscular atrophy is one of that, which is also a disease which can produce due to diverse pathologies. Etiologies could be many. And the characteristically, the symptom presents with the muscle wasting as a symptom initially, and the onset is insidious. The muscles which are involved are usually the proximal muscles, thicker muscles like the shoulder muscles or the thigh muscles which are involved, and the patient may not have any symptoms. Only there could be a visible atrophy, but the atrophy may not reach to that level where the patient may have a functional impairment in the beginning. Only after a long duration, patient may feel that the activity of the shoulder or activity of the thigh may become slightly weaker, and the patient feels that he is not able to do the same activities which he could do earlier. And it could be somewhere only in the some regions only. It may not occur everywhere. The presentation could be of different varieties. Usually another group of the muscle presentation could be the patient may have a sudden onset, as abrupt onset of the muscle weakness. That could be another of the presentation. And that in that presentation, the patient may have the distal weakness in the finer muscles. Now, see, presentation of focal muscular atrophy could be of a different category. The first type is muscle wasting, which is seen as in the thicker muscles. Then comes the muscle weakness, which occurs in the periphery, and which is usually of abrupt onset. And the patient may have the weakness of the distal muscles, finer muscles, and hence the patient may present with the symptoms like difficulty in finer jobs like opening jaws, holding tightly to a pencil, or typing, fingering of a musical instrument, buttoning a shirt, or so on. Such fine jobs, patient may find it difficult, and maybe at times the patient may not be able to do these also. And that later on it may result in proximal weakness in the upper limbs first, and then gradually lower limb, where the patient may not be able to raise the arm as such. Then it comes to the weakness of the lower limb muscles, resulting in difficulty in walking, climbing stairs, or walking on uneven surfaces, stumbling over small objects. So symptoms may present in a progressive fashion, where initially the smaller muscles involved and then the bigger muscles are involved, and that could be another presentation. The third type of the presentation could be muscle twitching, and where the patient may still have the normal activity, but only the twitchings could be seen. Patient may have that spasms, or when you look at that area muscles, you may see fine movements of the muscle body which are not tremors, and that's the could be the clinical presentation. And it again can later on gradually progress into the later conditions. Then the fourth category is where the patient may have the muscle cramps, and particularly often seen in the gastrocnemius muscle, which again is often confused with the other simpler causes. Like, see, cramps are very common when the patient is slightly dehydrated or overexerted, and many of these conditions may be often considered as such transient phenomena. But when the patient develops the cramps almost regularly, almost every day, then you have to think of a possible neurological pathology or a neurological induced muscle atrophy or focal muscular atrophy changes like. And then it may be brief intense pain, and the whole muscle may become hard at that time, and there could be immediate relief on stretching of the muscles. That is the characteristic feature of the cramps. A few of the patients also may have a sensory symptom like pain, numbness, tingling and so on, which again suggests the involvement of the nerve roots and the peripheral nerves. And one more category would be patient may have the trophic changes when the small fibers or the peripheral muscles are involved, where the patient may not be able to sense the pain, temperature or joint position, etc. Sensory abnormalities could occur. Now these are the major types of the presentation of focal muscular atrophy, and there are, if you look into the neurological textbooks, you may have still more, and as I told you, these symptoms variations are named with the different syndromes conditions. Now of course that's about the literary part, so I would like to minimize that. As far as the patients whom we see quite frequently in India and of course in some of the eastern countries, they are considered also as focal amyotrophy or Hirayama disease, wasted leg syndrome or monomelic amyotrophy. Now the most of the symptoms which we see, patients whom we see, I am just referring to the variety of patients whom we see as such. I am not talking about the general incidence as per the global statistics. Global statistics gives a different issue, but as far as the statistics in India and among the patients whom we see, a large number of patients with the muscular atrophy, focal muscular atrophy, present with the symptoms of this sort, where the muscles of the upper limb are wasted, and very often it may be presented with a cervical pathology. I think we have treated a good number of such patients, where the patient may have been diagnosed as a spondylitis with the MRI scan, but it may not be, there could be slight compression over the nerves, but that may not be the real cause for the compression as such, and the patient may have that neurological deficit as such, and this is also called as focal amyotrophy or the same focal muscular atrophy or Hirayama disease or wasted leg syndrome or monomelic amyotrophy. These are the different nomenclatures used as such. As far as the treatment is concerned, there is no curative treatment. What is done in the contemporary system is a high dose of steroids often are changing the course of the disease. Then growth hormone is prescribed, and amantadine also is prescribed. Chandraprabha Ekagvira Shugandharishta show marginal benefits, which we have treated a few of the patients. Of course, with the Basti also, usually Rajayapan Basti is given, but the outcome is poor as such. Then comes the spinal muscular atrophies, another group of these. And these spinal muscular atrophies are a group of autosomal genetic disorder, where autosomal recessive gene is responsible for that, presents with weakness of the lower motor neurons. Incidence of spinal muscular atrophy is about 1 in 10,000 in live births. At the time of the birth itself, one of that important issue is that spinal muscular atrophy can be present with the different types. The types are, again, there is a confusion with the, or maybe a difference of opinion in the classification. The earlier classification was spinal atrophy with the 0 to 4. Now the types are categorized into 1 to 3, and in 1995 the gene responsible for this SMA type is identified, and the chromosome also is identified now, and now hence based upon the genetic conditions they are categorized into SMA type I. SMAC classification now is based on the age of onset now, whereas earlier classification was something different. where it was type 0 to 4, now it's a type 1 to 4, because type 0, often the patient may have a stillbirth, child may have a stillbirth, and hence the present classification is a spinal muscular atrophy type 1 is also called as acute infantile or Werding-Hoffmann, where onset is at the time of the birth, or within 6 months, and the prognosis of that condition is poor. Then a chronic infantile is when the onset of the symptom is between 6 to 18 months. That is a type 2. Gradually the prognosis becomes somewhat better as we go into the higher types. Type 3 is chronic juvenile, where the onset is after 18 months. Type 4 is adult onset, where onset is somewhat later and usually in the mid-30s as such. Presentation of these symptoms are in the acute infantile or Werding-Hoffmann disease. These symptoms are presented in the flaccid muscles of the body or hypotonia, and when you hold the child like this, the typical hypotonia is seen when you hold the muscle or when the child is lying down. And very characteristically, the flaccidity doesn't affect the facial muscles. The facial muscles look normal, and that's one of the characteristic evidence of the spinal muscular atrophy in neonatal conditions. And the patient may have a difficulty in sucking, swallowing difficulty also may be there, and the respiratory failure also may be produced there. Once the condition has been diagnosed, Werding-Hoffmann disease is considered diagnosed, in 95% of the cases, the fatal complications would occur, and the fatal complications are respiratory failure, respiratory pathologies which are produced due to either aspiration or simply insufficiency of the ventilation, that the patient may die, and the average survival period now is considered as 5 to 9 months. There is absolutely no curative treatment. All the treatment would be to maintain a proper respiration and proper oxygenation, so regular suction of the respiratory tract, and then oxygenation if necessary, providing the oxygen from exterior, as well as the other major challenge would be to maintain the nourishment, nutrition, and but outcome is very poor in type 1 spinal muscular atrophy. Type 2 is chronic infantile, where the symptoms will be seen by the time the child starts moving about and then trying to sitting like, and there will be a failure to stand by 1 year of the age is one of the characteristic feature, or there could be postural tremors affecting the fingers. Now postural tremors in sense, in certain positions child may have the tremors like. Even there could be a pseudo hypertrophy of the gastrocnemius muscle could be seen, and there again the lifespan is around 2 years to the third decade of life, like 2 years to 30 years of the age. That's the maximum life period expected in such chronic infantile form, and such patients may not be able to do any normal day-to-day activities, but with the support they can live, and most of the times the fatal complications would occur due to respiratory infections. Again, the treatment protocol, there is absolutely no curative treatment now, and all the treatment is to prevent the respiratory complications. Then the type 3 is chronic juvenile or Kugelberg-Bellard syndrome, where there could be slowly progressive weakness, proximal weakness in the sense thicker muscles are involved, and they can stand and walk but have trouble with the motor skills. They may not be able to do the normal day-to-day activities. They cannot lift or hold an object, or they may find it difficult like going up or down the stairs, but they can stand, they can walk in the level ground as such. Bulbar dysfunctions may occur, like bulbar dysfunction in the sense swallowing and speech effects may occur in the later period also. Then patients may even show the pseudo hypertrophy as in type 2, and some of the patients can have normal life expectancies with the difficulties. With all the deformities, they can live to the normal extent. The usual clinical presentation in that such patients would be, you may be able to see the atrophy of the muscles in this area and the pseudo hypertrophy of the calf muscles. The presentation could be like mild winging of the scapula, and the position, to compensate with the position, patient may develop a scoliosis, and these are the, and if you look at the muscles, because of the flexibility of the muscles, there could be thick skin folds. So these could be the different clinical presentations in the later part of the life. Type 4 is adult onset form, where onset is typically in the mid 30s, after the 30s age that, and the disease mimics symptoms like the type T only, similar, and the overall the disease course is benign and the patient may have a normal life expectancy but with the difficulties as such. Now again, as far as these variants are concerned, I have given only these four categories based upon the ISMAC classification. If you look at the textbooks, you will have some 15 variants are named with the different names as such. Again, it is totally confusing and absolutely no use of this. So that's why, to minimize the details, I have not gone into that. And all these are named with the different complex syndromes names. And these syndromes do not make anything specific except for a type group of the muscles being involved. So I think we can skip that part. Then confirmation of the diagnosis is better done by the CK or creatine kinase, CPK, creatine phosphokinase is the investigation. And in type 1 in children, newborn, it's generally normal, it's not affected. But in the later types, it is elevated. And CSF findings also are normal. Muscle biopsy can confirm that. Now, as far as the curative treatment is concerned, in 2016, just around 7 years back, a new drug is introduced, and that's nusinersen or Spinraza is one of the drugs which is claimed to have advantages as such, and it's the first drug approved to treat children. The cost of the drug is very issue. Cost of the drug for 5 milliliters is now around the 12 milligram for 5 ml. 5 ml drug is $1,45,219 for 5 milliliters, and so virtually that kind of a treatment is beyond reach. I think there was a recent news report where one of the patients in Bombay, that child was treated with this imported Spinraza, and the outcome was the child died after 2 months. So it was some crores, multi-crores, where the central government had given some subsidies. I think you might have seen in the newspaper. But from the theory point of view, this is claimed to be the drug of the future, and particularly in newborn conditions to treat the children, this could be one of the drugs which may produce some change as such. Hopes are there. As far as the clinical experience from our side is concerned, virtually there is not much as such. May not be any significant improvement. The same protocols which we have discussed in the other motor neuron disease can be applied, like Chandraprabha, Virashogandha, with that the adult type can be managed somewhat. As far as the newborn, I don't have any experience of treating such conditions. That's about the spinal muscular atrophy. Now, because we are discussing about the muscular atrophy, we also discuss the muscular dystrophy. The difference between the word atrophy and dystrophy is where the bulk of the muscle is reduced. Dystrophy is where the muscle growth is affected. It's abnormal growth, usually hypertrophy. Thicken as such. It's not hypertrophy. Hypertrophy where the normal structure but the bulk is increased. Dystrophy is the bulk may be increased but the structure is normal. Instead of the normal muscle fibers, it will be replaced by either the fat substances or many times non-collagenous other substances, and hence the bulk of the muscles could be increased. That condition is called as muscular dystrophy. Now, it's also defined as muscular dystrophy is considered again not a single disease, collective group of inherited, non-inflammatory and progressive muscle disorder without a central peripheral nerve abnormality. So, muscle dystrophy is a non-neurological condition in majority of the conditions. But I have referred to this issue in the discussion of neurology because we are discussing about the muscle atrophy. At the same time, a muscle dystrophy could be relevant. And the disease affects the muscles with the definite fiber degeneration but without any evidence of morphological aberrations. Now, muscle dystrophies are again, there is a typing error, it should be strophies, not dystrophies. Sex-linked muscle dystrophies, that's Duchenne's or Becker's or Emery diffuse. Then autosomal dominant muscle dystrophies, facioscapulohumeral, distal, ocular, oculopharyngeal, and autosomal recessive, that's limb girdle form. These are the major three categories of the muscle dystrophies which we see. Among them, Duchenne is more commonly seen. The characteristically in the heritable muscle dystrophies, no abnormality is seen at the time of the birth, and the symptoms could be seen when the child starts begin to walk or when they lose their ability to ambulate, that's when they are not able to move, or rarely a muscle dystrophy could be diagnosed when the child dies suddenly. The clinical presentation of Duchenne's muscular dystrophy is usually the Gower sign, where the child is not able to raise up without support. So characteristically, when the child is made to stand up from the sitting position, the patient goes into all the four limbs, then gradually the child supports using the hands and then stands straight. As the condition progresses, initially the patient may stand, but later on the standing position would show that a significant amount of changes in the position of the neck and back to maintain the position against gravity, or the child may be totally dependent on the wheelchair. Then Becker's muscular dystrophy is where the muscles throughout the body are affected, and characteristic presentation of the shoulders are usually moving backwards, backside awkward during barking, and the abdomen seems to be pushing forwards. The back would be bent more forwards, knees may bend back, like there is a typical bending back of the knee, and the muscles, because of the weak muscles, the patient may have a foot drop like appearance. This could be the presentation, and that's called as a Becker's muscular atrophy. Then the Emery diffuse muscular dystrophy is also called as LMNA, and there the patient may have the involvement of the paraspinal cervical contractures. Heart muscles are involved quite frequently, humerus muscles and anterior compartment muscles, and the gait could be very typical, like the child may be walking with widely kept legs. There could be atrophy of the muscles, and the position of the body may not be in a straight line. Then comes the facioscapulohumeral, where the muscles would be atrophied and the winging of the scapula could be seen, and the patient, that's very characteristic. And the distal muscular atrophy is where the outer distal most muscles, the finger muscles, are involved, and particularly finger muscles, thigh muscles, both in the upper and lower limb could be involved, and the patient may have a visible abnormality and as well as a impaired control over that. Then ocular or oculopharyngeal is another presentation of these muscular dystrophies, where the patient may not be able to open the eyelids fully, resulting in a impairment of the visual field. The visual field would be constricted as the eyelids are not able to open, and this may be confused with the myasthenia gravis like conditions which need to be ruled out. Then limb girdle muscular dystrophy is where the muscles of the shoulder, muscles of the thigh are involved. There could be hypertrophy, and the position of the body would be of that sort. Now, diagnosis again, the CPK is the most important one. Creatine phosphokinase determines the most specific test for muscular dystrophy. As far as the muscle atrophy and dystrophies are concerned, or motor neuron disease is concerned, to differentiate that, the CPK, creatine phosphokinase, is the more dependable. That's what you have seen in many of the patients whom we treat. We always go for the CPK study and then decide like whether it's a neurological or muscular dystrophy, and many times the diagnosis is made. Transaminase levels also would be higher, lactate dehydrogenase levels and aldolase levels may be higher. There is a specific test, the multiplex polymerase chain reaction also is done often. Muscle biopsy is the one confirmatory diagnosis. Complications, the most important significant complication of the muscle dystrophy is a cardiopulmonary failure. The other complications which can occur due to the postural and effects of the gait, and the muscles muscles may go into contract and the patient may be on wheelchair continuously. Due to the weakness, the patient may have The osteopenia or osteoporosis also can occur, which can result in the fracture. Scoliosis can be the issue. Treatment, there is no curative treatment known, and the most important aspects of the management would be to cardiorespiratory management. That's every patient of muscular dystrophy has to be confirmed for the involvement of the cardiac muscles and the same cardiological principles. Again, I will not go into that issue. Cardiorespiratory management is the one, and if the patient has a swallowing difficulty, support for that with the degradation nourishment support. Now, skeletal supports like either wheelchair is the gross. Now, you may have different sorts of the splints and supports which could be used. As far as clinical experience is concerned, again, I would not say that it can be cured, but many of the patients may find some better results with the same Chandrapurva Kanvirashwarandharishara. The treatment line is almost same as the muscle atrophies, but outcome of course is poor. So with this we will conclude today. We will continue in the next class with the diseases like Parkinson's and other demyelinating disorders. So muscle dystrophies and atrophies and peripheral motor neuron diseases almost we have completed. Though it's not a total complete discussion, I think we have minimized the details to that level which is absolutely needed from the clinical point of view, minimized it. If there are any questions, I will try to answer. No questions, so we will conclude. Bye.